It will also strengthen our international pandemic research partnership to build a network of partners and allies to play our part in strengthening global surveillance of emerging pathogens. We will leverage GIZ. GIZ played an instrumental role during the COVID-19 pandemic. It is a global non-profit platform for open sharing of genomic data of viral pathogens, and today is the world's largest repository of SARS-CoV-2 sequences. Singapore will work closely with GIZ, and they have established a base here in collaboration with A*STAR. After we understand the characteristics of a dangerous pathogen, what do we do with the information? Having gone through SARS, H1N1, and the various phases of COVID-19, we have developed a range of responses. The characteristics of the pathogen will determine our response. DPM Wong, yesterday, he mentioned this briefly in his opening speech, but let me elaborate a little. Mr. Speaker, sir, can I show a chart on the screen, please?
Please do.
Not this one. Okay. Okay, yep. We can plot pathogens on a graph. In this chart, the horizontal axis measures transmissibility. Yes, we can freeze there. And the vertical axis measures severity. It is a simplified way of measuring the 6 characteristics that I spoke about. So if you notice at the top right-hand corner that looks like a durian or explosion, that is disease X, the disaster that we dread, but the pathogen has high transmissibility and high severity, and is deadly. And if you move to the left, you notice the red dot, that's SARS, with high mortality but low transmissibility. And so when you encounter something like that, it favors a strict containment approach, extensive contact tracing, chase down, isolate every case until the virus is eventually wiped out, which we did. As for COVID, which is the blue dot, you notice there's a blue dot near the red dot connoting SARS called COVID-19 wild type. That's the initial COVID-19. When it first appeared, the wild type strain is slightly southwest from SARS. That is why in the early phases of the pandemic, we treated it like SARS and adopted a zero COVID-19 policy. But over time, COVID-19 mutated. As it mutated, became Delta, became Omicron, BA1, now we got XBB, XBB 1.5, 1.9. They are constantly moving to the right, meaning they are more transmissible. But with vaccination, we don't just let them move to the right, we also make them move down and suppress the severity of these strains. So you see the blue dots now moving down closer to the green dot where influenza is. So overall, with vaccinations, later variants are closer to where influenza is on the vertical axis, which is why we are then able to open up and move towards living with the virus. So using this framework, what happens when a new pathogen of concern emerges in future? We may have to respond quickly with appropriate border and domestic SMM measures to minimize infections and to buy time. Then, with good science and the local and global capabilities I just described, we hope to quickly ascertain key characteristics of the pathogen, where it lies on the graph, and then determine the right responses. Concerted efforts to develop and secure effective vaccines and therapeutics will proceed in parallel. Third area of improvement, which is MOH will restructure to strengthen our organization. This is something we also did in the wake of SARS outbreak in 2003. MOH put in place a pandemic preparedness plan involving the primary care sector, which evolved into today's PHPCs, or Public Health Preparedness Clinic Scheme. Polyclinics and PHPCs served as our first line of defense to test and treat COVID-19 cases. They support home recovery. They also administered vaccinations and helped in surveillance efforts. So contrary to what Mr. Leon Pereira said, our family doctors actually, they have been and will continue to make an immense contribution during the pandemic and for healthcare in the future. We set up the NPHL, the National Public Health Laboratory. It conducts laboratory surveillance of infectious diseases and AIDS in outbreak investigations. When COVID-19 first emerged in Wuhan, it was the scientists from NPHL who designed the PCR test for COVID-19, 2 days after the scientists in China shared the genome sequencing with the world. We established the NCID, National Center for Infectious Diseases, which opened its facilities in 2019. And it provides high standard of infectious disease clinical management. These organizational enhancements after SARS built up capabilities that helped us respond to COVID-19. Given what we have learned from COVID-19 pandemic, we should once again review our organization structure to better prepare ourselves for the next pandemic. The one big lesson this time is that we need to rely on the wide repertoire of responses. As I explained in the charts earlier, each pathogen has unique characteristics, needing different responses. In fact, COVID-19 shifted around the charts, requiring us to change playbooks along the way. Specifically, for a severe but less transmissible disease like SARS, we need an individual-centric approach, comprising testing, isolation, tracing, quarantining, that is precise, accurate, and as error-free as possible. But for less severe but highly transmissible pathogens like Delta or Omicron variant, it becomes almost impossible to contact, trace, and isolate, especially as the disease increases and spread exponentially. It is also of no use insisting on gold standard accuracy and precision. Instead, we need to manage the exponential growth of infected persons through population-wide interventions. Mask wearing, ART tests in the community, self-tests, quarantine those, self-quarantine for those who are exposed, home recovery for those with milder symptoms. The individual-centric clinical approach versus the population-based public health approach, they are actually not mutually exclusive. In fact, they complement one another, and we adopted both during different phases of COVID-19 pandemic. We should institutionalize both sets of capabilities for the long term and able to deploy both with flexibility and dexterity in future pandemics. To do so, we will set up a new Communicable Disease Agency, or CDA, under MOH. It will oversee disease preparedness, prevention and control, surveillance, risk assessment, and outbreak response. This new agency will consolidate the relevant public health functions that today reside in MOH, NCID, as well as the Health Promotion Board. The NPHL, the laboratory, is a critical national resource and will be transferred to the CDA. The CDA will maintain oversight of the clinical facilities in NCID. Many countries such as South Korea, UK, and US, they have similar setups. They too, after COVID-19 crisis, is also reviewing their organizational setup. In addition, MOH will separately retain a permanent crisis strategy and operations group in the ministry. We call it CSOG or CSOC. CSOC was established during the pandemic and grew steadily as the pandemic progressed. It is the machinery behind all the pandemic-related operations that we are familiar with. Contact tracing, home quarantine, conveyancing to isolation facilities, testing, vaccinations, home recovery. All this coordinated and implemented by CSOC in MOH. CSOC was staffed by officers from various ministries, contract staff, and also staff from industries affected by COVID-19. For example, we had quite a number of SIA pilots as well as cabin crew working in CSOC. Most of these staff have returned to their industries. As Ms. Polisan said, as it rebounded from 2% to 80%, we lost all of them, but yet we're sad to see them go, but we are happy that they are gone too, because they are going back to their industries. So the operations have scaled down greatly. Nevertheless, we will keep a permanent CSOC force to maintain surge readiness for a mid-sized outbreak, as well as other health emergencies. And this includes preparing healthcare institutions to be crisis ready. In peacetime, when there's no emergency, they help us operationalize Healthier SG. As the skill sets turn out to be fairly similar, because it's not surprising because they are both public health focused. In addition, we will set up a healthcare reserve force made up of ex-healthcare workers and volunteers. We will train and equip them to reinforce our operations during larger surges, and they will complement the existing pool of SG Healthcare Corps volunteers. Finally, we will change the title of the DMS. Instead of Director of Medical Services, he will be called Director General of Health, which more accurately describes his role as the main overseer of both clinical and public health of Singaporeans. This will take place after the changes to the Healthcare Services Act come into effect later this year. This House has already approved the changes. With these changes, MOH will be organized to place greater emphasis on both clinical services and public health. They require different instincts, considerations, capabilities, and skill sets. Both are important and critical and will be institutionalized and built up within MOH. Let me now address a question that relates to public health measures, specifically on the issue of masking. Mr. Gerald Gian suggested the government was not forthright with the people, or that's what I heard, that during the initial stages of the pandemic, we did not impose mask requirements, not because of public health reasons, but because we did not have enough mask supplies. This is incorrect. In the initial stages of the pandemic, there was no clear understanding of the characteristics of the COVID-19 virus. We therefore align our policy to WHO's recommendations. And WHO, even up to March 2020, maintained that, and I quote, "A medical mask is not required for people who are not sick, as there is no evidence of its usefulness in protecting them." Unquote. The risk of shortage of masks for healthcare workers will put their lives in danger because they are in the front line. Is it a serious concern? It was. But it was not the basis of the prevailing public policy on masking. We aligned our policy with WHO. We reviewed and changed our masking policy in April 2020. That was also when WHO changed its guidelines, once the evidence on how the virus spreads became clearer. Particularly, there was now clear evidence that there was asymptomatic transmission via aerosol. Nevertheless, as acknowledged in the white paper, the whole issue of masking is one area where our decisions could have been better. But no question that during this period, government was totally forthright with the people and told the people what we knew. The fourth area of improvement is to update our laws. The Infectious Diseases Act, or IDA, is the principal legislation for the prevention and control of infectious diseases. It empowers MOH to take various public health actions for disease outbreaks, such as contact tracing, isolation of infected persons, testing of contacts, or the disinfection of premises, etc. The IDA also provides for the Minister for Health to declare a public health emergency in very grave public health situations, and that will activate extensive powers for the Minister